Hi, this is Dr. Nick with the ECG Academy, and I'm going to be finishing my discussion of AV node dysfunction with, yeah, you guessed it, third-degree AV block, also known as complete AV block or complete heart block. So what does complete heart block mean? Well, as I mentioned, first-degree AV block means all the P waves conduct, it's just that the PR interval is longer than 200 milliseconds. With second-degree AV block, some of the P waves fail to conduct, and depending upon if the PR is variable or if it's fixed, it gives you either type 1 or type 2. High-grade AV block is either 2 to 1 or 3 to 1 or something along those lines, but some are still conducting because second-degree AV block means only some of the P waves block. Well, third-degree AV block means none of the P waves are able to get through the AV node, and so the ventricles are not getting the signal. Does that mean you have no heartbeat? Well, usually not. Otherwise, you wouldn't be doing an electrocardiogram. You'd be doing an autopsy. Okay, maybe that's morbid. But if you remember my discussion of sinus node dysfunction, if the ventricles don't see a heartbeat, then what happens is a lower pacemaker center will pick up the slack. So in the case of sinus node failure, severe sinus bradycardia, usually the AV node will start to fire and you'll have a junctional escape focus. As you know, junctional means the AV node. It's the junction between the atrium and the ventricle. Those escape rhythms are usually for the AV junction in the range of 40 to maybe 45 beats per minute. But what happens with AV block is you'll get an escape rhythm, and it could be from the low junction. If you recall, the AV node is connected to the His bundle, but there may be an area down in the lower part of the AV node that would be able to take over. So you can sometimes see escape rhythms in the range of 30 to 35 beats per minute coming from the AV junction. If the AV junction is diseased also, then you can have escape rhythms that are arising from the Purkinje systems, from those fibers down in the ventricle. And those usually give rise to very slow escape beats with wide bizarre QRS complexes known as idioventricular escape rhythms. Idioventricular means it's coming from the ventricles, and usually you'll see rates of 25, maybe 30 beats per minute in idioventricular escape. Those are generally very wide-looking escape rhythms. It means the ventricular rhythm will generally be regular because it's coming from some escape focus. The P waves, of course, will be marching on through, and none of them will be getting through to the ventricle. All right, well, how does that look? Well, here's a good example of complete AV block. If you look at this electrocardiogram and scan across with your eyeballs, look at the forest and you'll see that the QRS complexes are there. And they look to be fairly regular, although rather slow, right? Let's find a QRS that lands on a heavy line. This one's pretty close. So 300, 150, 100, 75, 60, 50. And we're in the range of like 42 to 44 beats per minute. So the ventricular rate's about 44, and when you look around for P waves, you see P waves, but they seem to be just kind of hanging out here. There's one, and scan across, and oh, there's another one. And but wait a minute. Here's one too, but when you look at this QRS, it looks like there's a P in front of it. Well, does that mean it's a normal sinus rhythm? Well, there looks like there might be a P in front of this one, but if you look across, there's no P here. Well, actually, you can see a little piece of the P that's occurring simultaneously with the QRS complex. And so what you have here is an atrial rate that seems to be marching on through, and you have to look at the atrial rate. Well, how do we figure out the atrial rate? Here's a P wave. The beginning of it starts on a heavy line. So let's count it off. 300, 150, 100, 75. So it's about 70. So the atrial rate is 70 beats per minute. And if you look at the P waves, they're up in 1 and they're up in AVF. And so what you're seeing here is a sinus rhythm at a rate of 70 beats per minute, but none of these P waves are getting through to the ventricles. Every single one is blocking. So as a result, the ventricular rhythm is a very slow escape rhythm at 44 beats per minute. It's perfectly regular. And it's coming from where? From the ventricles? No, because it's narrow, look at how narrow it is. It looks like a normal QRS complex. And so it must be taking the normal route of conduction down the bundle branches and to the ventricles. And so we would consider this a junctional escape because it's narrow, it's normal appearing, and it's at a rate of 44 beats per minute, which is about right for the AV junction. So to summarize, what do we need to say complete heart block is present? We like to see regular P to P intervals because, after all, we're usually dealing with a sinus rhythm of some sort at a rate anywhere between 60 and 100 and something beats per minute with upright P waves in 1 and AVF. So we have a sinus rhythm and the P to P interval is regular. The R to R interval should be regular as well because if you have complete heart block, then you should be dealing with an escape focus of some sort, and that is not influenced by what's going on in the atrium. The two chambers are not talking to each other. You have to make sure there's no relation between the A's and the V's. So even though there may be P's that don't conduct, make sure you don't have some kind of fixed relationship like 2-to-1 or 3-to-1. And finally, this is very important, the atrial rate should be faster than the ventricular rate. If there appears to be no relation between the A's and the V's, but the V rate is faster than the atrial rate, we call that AV dissociation. And that's something we'll discuss when we get into ventricular arrhythmias, like accelerated idioventricular rhythm and ventricular tachycardia. Okay, so for now, let's get some practice up here. So here's an ECG from my archives. Again, when you look across at the QRS complexes, you see that you can just eyeball them and see that they are regular. They march on through. You can take calipers to make sure that I'm not lying, but we have here a very slow rate. We'll count up milliseconds this time. 2, 4, 6, 8. 1 second, 2, 4, 6, 8. Almost 2 seconds. So the rates, if it was 2 seconds, it would be 30 beats per minute. So it's somewhere in the order of 32 or 34 beats per minute. The QRS is a little bit wide. This could be a junctional escape rhythm, or it may actually be a rising from a little further down in the conduction system. But this is clearly an escape rhythm. Where are the P waves? We're looking for P waves, and probably lead 2 is the best place to look for P waves because they generally will tend to be largest. Remember, from the sinus node, the vector is going down into the patient's left, so that would be lead 2. The other place you can look for P waves is V1. That's a nice lead to look for P waves because they generally tend to be kind of large there. So here are the P waves. Here's one. You can see another one peeking out from the QRS, and here's one, and here's one. And so they're marching on through. The atrial rate here is about 300, 150, 175, maybe 76 beats per minute. So you have a sinus rhythm at 76 beats per minute with complete heart block or third degree, you can say third degree AV block, and a slow junctional escape at about 32 beats per minute. And that would be the rhythm diagnosis here. Complete heart block is generally easy to diagnose, but you'd be surprised sometimes it's overdiagnosed. Let me show you one example. Here's an ECG that initially was thought to be complete heart block because look at how slow the ventricular rhythm is. Look at that. If we count off milliseconds, we have 1, 2, 3, 4. That's 1 second. 1, 2, 3, 4. That's 2 seconds. So it's less than 30 beats per minute. And it looks pretty narrow. So we got a very slow junctional escape at like maybe 26 or 28 beats per minute. And when you start looking for P waves, you say, oh, look at that. There's a P wave that's just hanging in the breeze. So then obviously blocked. And this one, look, the PR is really long, and then here's another one that blocks. So you'd say, well, the P to P interval seems to be regular, but then what you say, wait a minute, the R to R interval is not exactly regular. And so what do we have here? Well, look at the PR interval. It looks to be fairly fixed, and it looks the P is in the same relationship with the QRS complex in these 3 beats. And then you have these are blocked. So you'd say, aha, well, I know what this is. This is not complete heart block. Instead, it is, well, a lot of people would call this up Mobitz 2 because it's 2-to-1. Right? Okay? But what did we say in the last video? That 2-to-1 AV block is not Mobitz 2. 2-to-1 AV block is in its own category We call it high grade. High grade AV block includes 2 to 1, 3 to 1, 4 to 1. It's also called advanced AV block. So from here to here, at least, you have high grade AV block. It's neither type 1 nor type 2. Well, I want to show you something really cool. You see this area right here? Well, let me just blow this up here because you see there are 2 P waves in a row that conduct. And if we look at that carefully, let's blow that up. So this group of beats here is the same group of beats that I have down here. I just sort of blew it up. You can see with nice high resolution. There's a fair amount of noise, little tiny bit of electrical artifact in the baseline. But you can see the P waves, okay, which I've already marked here and here and here, and they march through precisely. Now let's look at the PR interval. Well, it kind of looks fixed, but let's get out our good buddies, the calipers. And what you want to do is you want to place those calipers right at the beginning of the P wave and open them up to get right at the beginning of the QRS complex where it just leaves the baseline. Okay, and you have a PR interval there that's about 7 small boxes. So that's 280 milliseconds, right? 7 times 40. Good. Now let's march on through and let's see what happens when we put the point on this P wave. Oh, look at that. It looks like the PR interval here is a little longer. Well, if the PR gets longer, like this, if you see the P is shorter, it's 7 boxes, and then here it's more like 8 boxes, and then it blocks. What do we call this? This is type 1 second degree AV block. Type 1, or a winky back in this case, is what occurs from here to here. Well, what does that tell you? That tells you that most likely the block is in the AV node and not below the AV node, because the AV node delays the signal as the signals get down, but block below the AV node would be expected to have a fixed PR interval because of the all or none behavior that you see with the His bundle and the bundle branches. So this is really winky back. So how do we get from type 2 to type 1? Well, you can't have both. And that's the point. This is not type 2. This is advanced 2 to 1 block, which is likely occurring in the AV node itself. And then what happens is the AV node conduction improves just a little bit in order to conduct 2 P waves in a row. And then you're able to demonstrate that the PRs are getting longer, so you know that this is type 1 right in this location. But it shows you that the degree of AV block can change from 1 second to the next. What you have to keep in mind is the physiology of it all. How does the AV node behave? It exhibits slowing of conduction with each progressive signal, whereas the His-Purkinje system is more of the all or none kind of behavior that you would characterize as type 2 second degree AV block with a fixed PR interval. All right, so we're getting into some major physiology here, but I just wanted you to understand the difference between type 1, type 2, and complete, and don't get confused when someone hands you a strip with 2 to 1 block and asks you, well, what is it, Mobitz 1 or Mobitz 2? It's neither. And complete heart block is obviously a whole different animal. Okay, the last ECG I'm going to show you in this section is pretty impressive. In fact, this is a patient who came to the emergency room with a heart rate of about 20. I was called to see him, and it appeared that he had this wide QRS complex going at an extremely slow rate. Here, if you figure it out and calculate it, it comes out to be 22 beats per minute. Wide QRS complex, but where are the P waves? Well, there were no P waves. This is an arrhythmia known as atrial fibrillation. There's a whole section about atrial fibrillation later in this course. But what's happening is the top chamber is kind of jiggling it around at a rapid rate, and what you see is the top chamber just kind of looks like there's continuous electrical activity going on. But with atrial fibrillation, the hallmark of that arrhythmia is that it's irregular. It's generally irregularly irregular. And not to open up a whole can of worms, we will talk about that in great detail in that section. But when you see a very slow, regular atrial fibrillation, this is often called regularization of atrial fibrillation. You have to, at that point, diagnose complete heart block, because normally you would see an irregularity, but what this is an idioventricular escape rhythm. So this is idioventricular escape rhythm, and it's going at a rate of about 22 beats per minute. And it's there because the AV node has failed in a big way, and this was a patient who wound up getting a temporary transvenous pacemaker inserted on Thanksgiving Day, in fact, and then he subsequently had a permanent pacemaker implanted. So what I wanted you to appreciate is the idioventricular escape. The QRS is wide. If you measure it, it comes out to be about 140 milliseconds. It's bizarre looking. There's these weird, bizarre T waves that you're seeing, and this is a patient with severe conduction system disease who wound up needing a permanent pacemaker. So with that, I'll end my discussion of AV node dysfunction. I think we've covered most of the bases, and I hope you have a good appreciation of how to diagnose AV block. We'll go on to the next section and start to talk about specific arrhythmias, including ectopic beats, in this basic section of the ECG Academy. This is Dr. Nick. Let me help you become an ECG expert too. And thanks for subscribing to the ECG Academy.